Like that voice just said, we're going to record this meeting, um, just so the folks who weren't able to make it live can catch this after the fact. But I appreciate everybody tuning in and coming to learn. I'm excited also to learn. We got three great speakers lined up today. Before we jump into it, though, I want to give a little level setting of what the goal of TAC2F is, where it originated and kind of what our aims are with it. So TAC2F, or Tactical Athlete Holistic Health and Fitness Seminar, is a series that started a handful of years ago. And really the primary goal of the TAC2F seminar was to bridge this gap we consistently see between research and actually putting that research into practice for the people who need it, specifically thinking about our tactical athletes. And so the goal of these seminars since the beginning have been to create an environment for researchers, for clinicians, for first responders, military personnel, and everybody in between. Give them an opportunity to sit within the same room and have discussions about what us as researchers are seeing as best practices in one way or another, and what actually might be practical to implement within these different tactical professions. So our goal today will be similar. It's maybe a little different since it's in a virtual format, but I think that gives us reach to share out good information a little more broadly. So I would like to encourage everybody today to think about what questions you have and pose those, because we'll have presentations and then we'll have some time for Q&A. And these events started as an in-person thing, and now what we're doing is we're flipping between having in-person seminars and online seminars again for that reach. So our next one will be in December, and we'll focus on recovery tools and different types of recovery equipment and the techniques that can be used for tactical athletes and the environments they work in, the unique occupational constraints that they have, and those loads as well. And so we're going to host this on OSU's campus. So if you're in close proximity, or if you want to make the trip, we'd love to host you here on campus so we can talk about these different types of equipment and do some demonstrations of those as well. So today we've got three speakers lined up. We've got Dr. Shannon White, who will lead off speaking about some of the sleep and system-related sleep research that she's done in the past, specifically trying to turn our minds into a human-centered approach. Dr. Mike Dial will bat second here, talking about all of the work he's done within wearable monitoring and the sleep metrics that they provide. And then closing out will be Dr. Graham McGinnis, who will discuss some of his research related to wildland firefighting and and circadian disruption and how those interact again with sleep and health overall. So I'm really excited for today. And without further ado, we'll pass it off to Dr. Shannon White, who is the Associate Director of the Collaborative for the Advancement of Health and Wellbeing at Ohio State. She completed her PhD at Penn State, and her research really focuses on biopsychosocial factors of health for tactical personnel, for folks within healthcare, and any paramilitary profession. So her training in psychology, also in behavioral medicine and translational science, helped her innovate with some of her approaches in order to make really impactful research approachable for everybody. So today her talk will be titled Turning Sleep Science into Action, a Human-Centered Approach. I'm excited to pass the mic to her. Dr. White?
Wonderful. Thank you, Nathan. Uh, so, did I share the correct screen? You think after 6 years of doing this,
Yep,
we
you
we
nailed it.
figure it out? Okay, wonderful. Um, so I'm very excited to be here today. This topic of research is near and dear to my heart, and I've spent basically the last decade kind of in and around this domain. So I want to be upfront about the title of this presentation. So there's no shortage of sleep science. What there is a shortage of is sleep science that actually fits the life of first responders. So today I'm going to walk you through how we took the science and built something with firefighters specifically that they would use. And I'm going to start with why this matters. So I have framed this as the problem, and I'm starting here on purpose because everything we cover today is kind of built on top of it. And so three groups, almost 14,000 people screened. Among firefighters, 37%, among law enforcement, 40%, and among EMTs, 70%. You may be asking what these numbers represent. And this is the number of people who screened positive for at least one sleep disorder. And so when we think about sleep, and before we go any further, I want you to see that sleep doesn't sit off in its own box. Everything on this wheel is connected to it, and every arrow runs in both directions. Sleep drives your cognitive performance, your physical and mental health. And those, in addition to your environment, your behaviors, and your shift schedule, turn right back around and drive your sleep. And the reason that matters for today is simple. Everything is connected. Then you can't fix sleep by lecturing one person about bedtime, which you'll hear I promise I won't do. But you have to work the whole system. And the idea shapes everything that I want to talk about going forward. So the question became, how do we take the research and actually move it into a firehouse, a precinct, an ambulance bay, or a hospital and have it stick? And this is the gap that we sought out to address. You may ask, why the human-centered design? Well, because traditional wellness programs often fail, and they keep failing in very predictable ways. They don't reflect the realities of shift work. They come across as judgmental or just irrelevant to the job. They're designed for first responders instead of with them. And there's a deep, well-earned distrust about how personal data is going to be used. And when you stack all those up, it's no wonder that the typical program often gets the shrug from individuals. We didn't want a better pamphlet or another training video for people to sit through. We needed a fundamentally better way to design the solution, and one that started with the firefighters themselves. So we built this as a multi-phase research program. A preliminary phase to understand the landscape and brainstorm ideas, phase 1 to observe and understand, phase 2 for prototype testing, and phase 3 to implement and evaluate the program that we had designed. It's deliberately iterative, and each phase informed the next. Today, I want to focus on phase 1, where we listened, and phase 3, where we tested what was built and measured whether it worked. So phase 1 was about listening, and we did it in 3 key ways. So first, we met with leadership to understand the operational constraints that we would be under running this program. This was also to create buy-in. As many of you or all of you will know, when you set out to work with these populations, that buy-in has to come from the top before we were even allowed access to operational members of the department. We embedded in their workspace. We showed up in stations to see how the job is actually done. And we ran semi-structured interviews with firefighters themselves. And the goal wasn't to confirm what we already thought, but it was to be told what we were missing. And this is what immersion looked like. It was on the bay floor, on the training ground, and in the apparatus. And I learned things standing in a firehouse at 2 a.m. after getting back from a call that I would have never learned from a survey. And so what did they tell us? So what we heard from firefighters on the sleep barriers front was they had trouble falling asleep, trouble staying asleep, and long commutes impacting pre-shift rest. And so one participant told us, it's not consistent. I try to go to bed at a decent hour and it doesn't mean I'm sleeping. And this quote perfectly articulates what was consistently coming across in these interviews when we met with firefighters, regardless of their years of service or their rank in the department. This was consistent. On the program side, the message was just as clear. It had to be simple. The program had to be a low burden. They wanted their data and feedback, but on their terms. And there was real skepticism, towards existing wellness programming and what was already being run and delivered by the department. My favorite line, because it's so honest, was it has to be simple. The older guys will look at you and say, I'm not doing that. And there was some swearing removed from that quote, but I think it articulates perfectly. And this quote became a design requirement as we moved forward. So We had the science and we had the truth from the floor. And the question was, what now? How do we turn all of this into something real that people would actually use? So it became a task. The program had to be 5 things all at once. It had to be simple, minimally disruptive or not disruptive to the demands of the shift, but also to their personal lives away from shift. It had to be tailored to firefighters specifically and not borrowed from a corporate wellness program. It had to be evidence-based so it actually worked, and it had to be enjoyable. And this is one step that is often a mistake to skip. And if people don't like it, they won't do it. And a program that nobody does has 0 impact. So all pretty simple. Okay. So we built the FIHOT program, or the Firefighter Integrated Health Optimization Training Program, and had 2 targets that we know to reinforce each other: sleep hygiene and physical activity. Today, I want to focus on the sleep hygiene element of this program. So we anchored this entire behavior change program around theory and what actually makes that change happen. So people change when 3 things line up. Can I? So does an individual have the skills and the knowledge? Will I? Do they have the drive and the motivation? And finally, could I? Does the opportunity present itself given the real scheduled demands and constraints? So most programs only hit one of these. They usually throw information at can I and call it a day. But we designed the program to support all 3 of these at the same time. So it's a large jumble of what you see on screen, but what you see is the entire 12-week FIHOT program design in its entirety. So the program was comprised of 2 site visits, and these were conducted in stations where we collected cardiovascular disease risk indicators and anthropometric assessments. The 12-week study period included a 2-week run-in period where participants were just asked to wear their Fitbit devices and not respond to any surveys or do any sort of intervention program. The 8-week intervention period and a 2-week run-out period where, again, participants didn't do any of the interventions. They wore their devices and went about their lives as normal. And during all 12 weeks, again, we continued to ask participants to wear their Fitbit devices that we had provided. So this is the sleep hygiene piece up close, and it's intentionally small. So on the intervention day, a brief micro intervention was delivered in the evening, about 8 p.m. This included a short podcast and a relaxation video. These were delivered around 8 p.m. I want to preface that the sleep podcast topics were picked based on feedback that we had received during phase 1 interviews. We wrote and recorded these podcasts to present the science in a way that was easily digestible and could be done within 5 to 7 minutes. And the following day, there was a morning survey delivered at 5 a.m. and an evening survey delivered at 8 p.m. In addition, a program resource reviewing the content of the prior night's sleep podcast to reinforce it was delivered. And these resources included additional readings that participants could navigate to if they felt necessary. So this was it. It's not a big time commitment. There was no equipment, nothing that announced itself in front of a crew. It was simple and low burden, and exactly like they asked. And these interventions could be completed in less than 10 minutes. So the delivery of the interventions was deliberate as well. Interventions were scheduled randomly, twice a week, and never on the same day. The randomness let us actually test the effect. We could compare the days we delivered something against the days that we didn't in the same person. And that design choice is going to matter a bit more when we get into the programming, or we get into the findings here shortly. And I do want to make a note that we never delivered a sleep program and a physical activity program on the same day as well. So reviewing the sample characteristics, we had 130 participants who completed the full program. Of the sample, 10% were female. The average age was 36. The average commute was 35 miles. Distances were calculated based on residential zip codes provided by the participants and zip codes for home stations, which gave us an estimate. I was later informed that the average department commute time is about an hour, hour and a half. And so this is the real working sample and not volunteers in a lab. At the time that we conducted this study, the 130 participants represented over a quarter of the operational field. So these were our device assessed findings, and I want to be honest about the nuance here. So total sleep time went up significantly across all study days, and that was a real win. Sleep efficiency, which is a measurement of how well someone sleeps, improved significantly on days that we actually delivered the intervention, which tells us that the tool works when it's in front of them, but noticed it dipped on non-intervention days. When we look at wakefulness after sleep onset, which is the amount of time that somebody spends awake after the sleep episode begins, you'll see the fragmentation and how uh, the negative increase that we saw was while the initial appearance of this is quite negative, when changing a sleep routine, it's not uncommon to see wake after sleep onset rise in intervention delivery programming. Okay. So when we looked at acceptability and program engagement, did they actually use it? And the answer was yes. And what we're most proud of is that 81% of microinterventions were completed, 80% of daily diary surveys were completed, 81% of firefighters found the program useful, and 90% said that they would recommend the program to others. So what we can step back and take a look at this and say, for a population that started out skeptical of wellness programs, this isn't just adoption, this is trust. And it's really kind of the grounds for the payoff of the human-centered design is really in this slide. So in the next set of slides, we're going to look at device data aggregated, and we aggregated it based on 4 levels. So when participants weren't on shift, so this was either not coming off shift or not going on shift. And individuals in this department worked a 24/48 with a Kelly day. So every seven scheduled shifts, they would be off, and that constitutes their Kelly day. We looked at before shift, on shift, and the night immediately following their 24-hour shift. We look at sleep architecture, and here's why architecture matters, and it's not just about hours. So healthy sleep, cycles through light, deep, and REM sleep all night. And this is what restoration looks like on a good night's sleep. So deep sleep repairs the body, REM sleep consolidates memory and regulates mood. And so when sleep gets compressed or broken, you don't lose it evenly. You lose it across the stages that you need most. And across a typical night, we see about 4 to 5 complete sleep cycles, each lasting about 90 to 110 minutes. So early in the night, cycles have more deep sleep. Later cycles have longer REM sleep periods. And adults spend about 75% of their sleep time in light and deep sleep stages. Okay. So when we looked at sleep across those 4 aggregated periods, a day off shift, firefighters got about, they got about 6.5 hours of total sleep time, which you'll see is that light purple bar across all 4 metrics. Sleep was roughly the same on the night after shift, a little bit longer. But what I want to draw your attention to is inside this red box. The night before shift, average sleep time was 4 hours and 45 minutes. The night on shift at the station was 4 hours and 44. That's nearly 2 hours less than on the 2 nights that matter most operationally, and deep and REM sleep also drop off on those nights. So big picture takeaway is individuals were going into their 24-hour tour already short on sleep and getting broken sleep within stations, then spending their days off paying back that sleep debt. And what we found was that wasn't rest, that was surviving and catching up. But it's easy to look at these and see a broad estimates of 130 people, but I want to show it to you in a single individual in the real world application. So here's one firefighter, male, late 30s, mid-career, had school-age children at home. Each point is 1 night's sleep, color-coded by day. And I want you to see this swing here. So before shift and on shift nights, that sleep craters. So we see it significantly drop off. We saw this night here coming off of his Kelly day, drop to 3 hours and 43 minutes going on to shift. So our key takeaway here is his body never gets a steady signal, and he's not an outliner. This is a pattern that we found across a lot of our participants. So what the data said, if you pull it all together, sleep on shift was short and broken. The days off became about catch up, and recovery gets harder the longer that you're on the job. And this was both, we found this anecdotally from perspectives of participants, but also what we saw in the data itself. And the bottom line is a lot of firefighters are functionally tired, but not rested. They're doing their job, they're doing it well on a sleep foundation that the schedule that they were working kept undercutting. So why does it matter? So behavior change alone was not enough. You can't will your way out of a 24-hour shift. There's operational constraints that these individuals have to work within. Timing for the delivery of these supportive contents and intervention matters a lot. The same supportive tool landed differently depending on when we delivered it. 3, small, easy, brief tools genuinely move the needle. We don't need to overhaul anyone's life, but helping them build the tools to improve their own sleep mattered most. 4, and this may be the biggest one, fatigue solutions are multi-layered and not individuals. So we didn't get this far by handing firefighters some sort of rule book that they had to follow. We got here by building this with them, and that was the whole approach. And this is how we turned the sleep science into something that actually holds up for them at 2 a.m. or when they get back from a call, and it's informative. So where I want to take this next is keys that we took from our participants. So this is going to follow two key themes. So health behavior awareness. We looked at strategic caffeine timing, and walking into a fire station or into a hospital, you hear the same thing of an individual being able to sleep with no problems after energy drink or coffee. It's not a question of when that how much is consumed. It's when that caffeine is consumed. And you may feel like you're sleeping fine, but what is the depth of that sleep and how restorative is it? I would encourage people to create post-shift rituals. So building routines that help themselves or encouraging members of your team to be successful, whether that looks like getting off shift and conducting brief movement, whether it be a mobility exercise or a brief workout in the gym or something that helps people train their bodies in that way. And finally, the revenge bedtime procrastination. And this is a health behavior to be aware of that we talk a lot about and continue to come up sitting at kitchen tables and stations. And this is the act of intentionally sacrificing late night or sacrificing sleep for late night leisure time because you felt like you have no control over your schedule during the day. And it is a subconscious rebellion against a busy and draining routine that often leaves people feeling exhausted or with a false sense of autonomy. This may look different for everybody, but themes that we saw pop up were scrolling on your phone, whether it be social media or through YouTube videos or podcasts or things like that, things that actively keep you awake. A few resources I do want to provide. So the first is a caffeine calculator, and this will help you be cognizant of behaviors. And so how much caffeine you're actually consuming, and how being able to tie that to the your sleep and your sleep quality. The second is a brain dump activity that's to be done before sleep. We found this successful with participants the night before shift when we see things like cognitive rumination or people thinking through all of the things that they have to get done the next day that keep them awake. And then finally, I've provided an example of the guided breathing activity that we used in that sleep intervention to help people fall asleep, where we saw the improvement in sleep efficiency. And I am happy to answer any questions.
That was great. Yeah, thanks for sharing and giving us a look. So anybody who has questions, feel free to pop them in the chat if you want, or you can unmute and go ahead and pose those. Yeah, really interesting stuff. While everybody's typing their questions out, I've got one to kick us off. Oh, Jimmy, you've got your hand up. Go for
it. Yeah, great stuff. Can you guys hear me okay? Mm-hmm. I love the idea when me and Nathan were texting back and forth on yours to revenge bedtime procrastination. I thought was awesome. What policies do you think they were open to changing, right? So like the 24, 48, like what's the low-hanging fruit from policy standpoint from your background that you think with this one group that you think is potentially implementable from a across the board standpoint?
Yeah, so in my time, so this study, you saw a very small portion of it, but it took place over 2 years. And so I was basically embedded with the department for 2 years. And so during my time there, they had implemented a napping policy, which was called basically a um uh forgive my memory, but basically it was a performance nap. And so
Mm.
that policy was implemented as basically a performance safety nap. So if somebody, one of the examples that was quite prominent was somebody's at home all night with a newborn, they come into work, they're sleep deprived, their performance is low, so their officer sends them for a nap, 90
Mm.
minutes to 110 minutes to get through that sleep cycle if it's possible, and then they're back out. They're not lying in their beds, they're not camping out in their bunks. And so that policy was implemented and was quite favorable. The trade-off with that, however, was this idea that the it was officer dependent, and so the policies can be implemented. However, they have to be accepted by officers in the station. The other implementate policy that they're looking at implementing in this particular department is they're looking at a shift schedule change in the coming months, and also a shift start time change was what we had proposed to the department. So this department's shift start time is 6 a.m. and the average commute time is about an hour and a half. So we're not really setting people up for success if they're up at 3:30 in the morning to work 24 hours and then potentially be held on 12 hours of mandatory overtime. So
Great, thank you. Appreciate it.
Yeah, it's a very interesting discussion about what can be put into the policy. There's a question in the chat that is an awesome question, kind of aligned with one I had. After a period of poor sleep, was there an average time period for recovery, or was it more individual specific? I'm thinking like after poor sleep, how much time do people need to recover?
so that a lot of that was very individually specific. We saw differences in people who went home and had families versus individuals who were single, and the time to recover looked quite different. People able to sleep in at the station versus those who had to get out at 5:30 and get home. So a lot of that is very individualized.
Yeah, that makes sense. I had a question about the kind of the first portion of your study that you talked about, and asking firefighters about their sleep habits and things, because a lot of times those questions are kind of personal because you're getting outside of, I guess in this case you're a little bit in the station, but also like what are you doing at home? And so what was their response to some of those maybe more probing questions, if you will?
It was a mixed bag. We it ran the gamut of people who took their sleep very seriously. So whether it was their sleep time routine and cutting off screen time and reducing caffeine and exposure to light before bed, and those who were like, well, I just do it. Like I just get into bed and I put my CPAP mask on and I go to sleep. And so it was really there was quite the difference in people's response to that. And others who, when asked that question, responded with, I've never really thought about it. And this is individuals who've been in this job for 10, 15 years and it something they just accepted as being a problem. And so I think we have a lot of work to do. And I say we collectively as scientists, we have a lot of work to do with retraining how people think about those things and what the impact looks like. And when we talk to people about the sleep and activity portion, as it was a combined program, it was really finding out what their goals were and then helping them tie why this stuff is important to those goals. So the individuals who are set to retire in 3 to 5 years, being able to be active with their grandkids and being able to travel with their spouse and those kinds of things. So circling back to your question, it was all over the map.
Yeah, that's some of the experience we've had doing similar things within law enforcement. Is it's all over the map, and it's interesting what people will talk about, which is good because it's like what's on their mind and impressing. Okay, I'll ask one more question, and then if anybody has any other questions, feel free to unmute and chime in here. But I'm curious about the station you were working with. work 24s, but there are a number going to 48s with 72 hours off. And have you seen any research similarly mapping sleep timing and staging to those?
Yeah, there's a body of research that's coming out right now. Uh, and so that's looking at departments that are making the change to a 24/72 or to later shift start time. There's some research coming out of Colorado. There's research coming out of Georgia that's looking at how sleep is impacted by changes in schedules. And a lot of it is quite beneficial when we push back start times. Um, then we're allowing people like more time in their own bed. When we look at changes in shift schedules from a 24/48 to a 24/72, there's an extra day of recovery if somebody has to work overtime or demands change or things like that. And so it's all positive, but a lot of that also comes back to what can counties and districts afford? Because to move to a 24/72 from a 24/48 requires additional entire shift. And so you now go from a 3-shift department to a 4-shift department. And that's not a small change, both operationally, but also financially. So significant, but yeah, there's data coming out that's quite positive.
Yeah, it does take that whole systems change to an extent.
Mm-hmm.
And this leads right into Steve Click has a question here about finding leadership to support this study and then also the findings and the implementation of it. So what was your relationship with leadership?
It was phenomenal. They supported us from the get-go. We met initially with the leadership team in 2023, and they were supportive of us doing this work and being in stations. And when we had proposed conducting site visits to catch people on their way home from shift, they basically said, no one's going to participate. Go in and catch them when they're on shift. No, we're not going to take them out of service, but you can catch them early in the morning, and we can do it that way. And we were set up with any station that we had participants at, we could set up there and go. We ran visits as early as 4:30 in the morning, and they had no problem with that. Incredibly supportive. There was a financial contribution to the purchase of study equipment and study materials. And then when the study concluded, there was support from the systems chief and the assistant chiefs that we get into the station and disseminate the findings with participants. So we hosted 11 different site visits across the county at different stations to make sure that people could ask their questions and understand what we found. So yeah, no, we couldn't have asked for a more supportive department.
Oh, it's awesome. I love to hear that. That's how research should flow back. The data should come straight back.
Yeah.
Okay. Any other questions out there? While people are thinking on that, Shannon, would you pull up those 3 QR codes that you had at the end?
Of course.
And what we'll do now, if you have another question, toss it out. But we're going to take like a 5-minute break here. I think we'll come back at let's come back at a quarter till. So we've got about 10 minutes. And so I'd encourage you either stand up, stretch your legs, move. I know it's afternoon meeting on sleep, so we don't want to fall asleep, or do a couple of these activities. Check in to see where you're at. Some of the those micro recovery tools. I'm curious to check out the caffeine one, especially.
Every time I go, this is funny.
Cool. All right, we'll tune back in. 2:45. We'll tee up Dr. Dial to talk about wearables. Perfect. Yeah, I got it. Thanks, Shane.
Mm-hmm.
Thanks, sir. All right, so our next speaker is Dr. Michael Dial. He's a research scientist at the Ohio State University in the Human Performance Collaborative, but he's embedded at the 711 at the Human Performance Wing at Air Force Research Labs at Wright Pat Air Force Base in Dayton. His research focuses on the validation and practical uses of wearable technologies in a lot of different senses, but specifically to measure and monitor sleep and recovery and physiologic readiness in tactical and athletic populations. He earned his PhD in exercise physiology from UNLV, where his dissertation examined circadian disruption and metabolic health. So Mike actively collaborates with a variety of academic and government and industry partners to continue helping the measurement of human performance move forward. So we're excited to introduce Mike to talk about sensors, from sensors to decisions, interpreting wearable data in tactical and athletic settings. Take it away, Mike.
All right, cool. Thanks for the intro. I am also going to try to share the correct. Oh, wait, hang on. I need to share that window. And now I'm going to do my slideshow and watch. Here we go. All right, you see my presentation?
It's like you're a pro.
Again, like 7 years in, and we're still all like every single time asking. Okay, before we start, a couple housekeeping items. Number one, my roof is actively being torn off and put back on. So if you hear loud banging noises, it's not you, it's me. Secondly, I may have a 4-year-old that might barge in at some point. That's okay. She's fine. And that's okay. And thirdly, the only reason that I have the letters PhD by my name is because our next speaker, Graham McGinnis, let me into his lab with like 6 weeks notice. So he's going to give a great talk. Also, just thanks to him. All right, let's hop into it. We're going to talk about wearable derived sleep metrics and what we can and can't necessarily get from the data. All right, so we're going to talk about 3 main things. The first, we're going to speak about specifically what is valid and accurate from these wearable sensors. Now, what sleep metrics are actually measurements and what are estimates or derived metrics. We're going to talk about how to individualize these interpretations and why me comparing my metrics to Nathan or to Shannon or to Graham might not be appropriate. And 3, that you are not necessarily your data. And if I feel great about my wearable, it says let us look like crap, how we can kind of, I hate to use this word, but hack that, but also the reasons why we monitor and not surveil, if that makes sense. All right, so first, not all metrics are created equal. How do we know what is accurate from these devices? It's because we always, as much as we can, we validate them against what we call a gold standard. So specifically, when we are asleep, we go through various stages. You've probably heard of deep sleep, light sleep, or REM sleep. All those are different sleep stages in which our body is doing different things. And the way that we can actually measure that is by changes in brain activity, which this person is not like dead, they're alive, very much so. And this is called polysomnography, which is a bunch of sensors put on your brain to measure changes in brain activity. And this is really the only way that we know to correctly identify the sleep stage that somebody is in. For a gold standard that many of you might be more familiar with is electrocardiogram. This is the gold standard way to get heart rate and heart rate variability, so the difference in the times between those specific heartbeats. There's the classic 12-lead ECG that you need a clinician to put on. But what has also been validated for electrocardiogram is just a 2-lead like this chest strap right here that we can use to accurately get the full ECG waveform and accurately measure heart rate and heart rate variability. It's important to understand that these gold standards, again, these are the highest level ways that we know how to measure these things. So that when we say that these wearables are accurate or off by a certain percentage or a certain metric, we mean relative to these gold standards that have their own margins of error. So we're always comparing them to the highest level that we possibly can. Okay. Now we'll get into what is generally in your sleep devices. So the main backbone of almost all of our sleep detection is based off of what's called an accelerometer. What you see here is this tiny little chip. That's what the accelerometer looks like. It measures movement or accelerations in 3 axes, so X, Y, and Z. So when you, I mean, when you think of the classic pedometers that everybody was wearing 15 or 20 years ago, you would put them on your hip and it just measures the steps via those accelerations. Uh, in the research world, accelerometers that were much chunkier and just gaudier than these watches were used to estimate sleep time, what sleep versus wake, and that's what's been built into all these devices that are on our wrists and fingers and arms. Yeah, I'm wearing several right now, one right there too. It's kind of weird that I'm only wearing like 6 of them, usually more. Uh, I digress. So the accelerometry, like it's very simple, but that is honestly the backbone of sleep detection and a lot of the metrics. Another important one is PPG. That stands for photoplethysmography. So that is essentially what it is. It's these green lights or red or infrared lights on our watches. They also have them in the new AirPod Pros that essentially shine a light into your skin, and then based off of how much light is reflected back. That changes based on how much blood perfusion is in the capillaries. And so what it does is it gets this raw waveform of light returning back to the sensor, and then we can derive heart rate from that signal. We don't necessarily need to know or be able to interpret that signal specifically, but they're very accurate at rest. So during sleep specifically, it's a good condition. The signal gets cloudy with movement, with changes in temperature, and so during exercise, they're not as reliable. Uh, Honestly, the accelerometer and the PPG are the main things that we'll talk about today. But in a lot of these devices, they also have skin temperature, which can detect changes in sickness and also be able to fairly accurately estimate menstrual cycle phase, and SpO2, which estimates blood oxygen saturation. Um, Everything that we're getting into derives from these sensors. The way that these work is if we start at the bottom here, we start at these raw signals like that PPG sensor, the PPG signal that we saw. And then we get into our derived metrics. So the app doesn't show you that signal. It tells you your heart rate is 75 beats per minute, or it says your heart rate variability is 60 milliseconds. Based on the accelerometry, it tells you your total sleep time, sleep versus wake, and your respiratory rate. Uh, we'll get into a few of these a little bit later. From there, from those derived metrics that we're actually estimating or actually directly measuring, we get into the estimated metrics, which are the sleep stages. Respiratory rate's kind of in there. That just comes from your heart rate speeding up when you inhale and slowing down as you exhale, and so it can estimate your respiratory rate there. And then we get into composite scores, so readiness, recovery, or sleep scores that lots of wearable companies report. Most of them are black box algorithms, so they don't necessarily explain how they are calculated. We have a decent idea of what's going into those, and we'll again get into that a little bit later. Uh, but just going to show that these sleep scores up here or recovery scores, they're a measurement. Yeah, sorry, they are not a measurement. It's a derived metric from these metrics that we are directly measuring or reasonably estimating. So we're going to get into specifically what has been validated from these sensors. And this is important as we'll get into what we can actually do with them. This is based off of 5 studies, about 1,000 nights worth of data, and most major brands were included. So Aura, Whoop, Garmin, Fitbit, Apple Watch, and there are many others as well. The main thing is that total sleep time is very accurate on average. So if you look at your app in the morning and it says that I slept for 8 hours, that's usually a good estimate. It's accurate to within about 3% in most situations. And something that should be said is these are people who have not been diagnosed with a sleep disorder and likely people who are not shift workers. We have a long way to go to validating these in those populations. And obviously, tactical populations are a large portion of that. So all of this needs to be taken with a grain of salt and understood how these were validated. But generally, total sleep time is a reliable and accurate measurement. Sleep versus wake is also very generally very reliable. Most devices seem to miss some of the wake times and overcall the sleep. Somewhere where I noticed that is when I have two little girls, and when my wife would be awake, very much awake, breastfeeding in bed, the ring or watch or whatever was very certain that she was just sleeping, which neither of us were, and so we can attest that they are not. So again, there are limitations, but sleep versus wake generally within about 10% seems to be accurate. Where it is not accurate are sleep staging. So light sleep, deep sleep, and REM sleep can be up to 30% off. Uh, in the very best situations, the best studies, which were probably funded by Whooper or whoever, it seems to be about 70 to 75% accurate against a PSG reference. And that holds true for all like sleep, all REM sleep, deep sleep, light sleep. Uh, but the most important things that we derive from that are our total sleep time and our sleep versus wake. So a lot of them will give you a sleep efficiency metric. So if it says that I was in bed for 9 hours and slept for 8 hours, I should have chosen an easier fraction. But you would essentially you can say that okay, I was asleep for 90% of my time in bed. Those are generally reliable, even if the exact number isn't right. Those trends will follow the actual metrics. And it's not necessarily that it's a technological limitation where these things aren't on our brains. They can't measure the brain waves. And so we can't accurately get those sleep stages. So we shouldn't rely on that. We should rely on the total sleep time and the sleep versus wake metrics. And if we give ourselves a proper sleep window, which again is difficult in some populations, our body will get the rest that it needs. And if we're deficient on REM sleep, your body will get more REM sleep when it needs it. So we don't necessarily need to worry about that unless we have a specific sleep condition. Also, we have our overnight vitals, so it's heart rate variability, and respiratory rate. The most trustworthy, the most well validated is resting heart rate. Some devices calculate it in the first 4 hours. Some do an all night overnight average. Some dynamically weight it to your last slow wave sleep cycle. It's kind of annoying how they all calculate it a little bit differently, but essentially your average heart rate overnight is very reliable, mostly because the PPG signal, the PPG technology to measure heart rate is very valid at rest. Usually accurate enough within 1 to 2 beats per minute. Most of these are contingent upon people wearing the device correctly. If you're wearing a watch or wristband that is super loose, it's not going to be able to get a good signal, and so that's also a consideration. Um, we'll talk about heart rate variability. This isn't necessarily an HRV lecture, but in a nutshell, if you're not familiar, heart rate variability it's a 30,000-foot view of your autonomic nervous system status. Our hearts, when we say 60 beats per minute, it's not necessarily beating once every second like a metronome. There's sometimes it speeds up, sometimes it slows down, and the amount of time between those heartbeats is what we're actually measuring when we talk about heart rate variability. And in a nutshell, lower heart rate variability suggests that you're shifted more towards fight or flight or sympathetic. Higher heart rate variability indicates more parasympathetic. So it's the inverse of what we typically want to see with resting heart rate, where we get healthier, our resting heart rate decreases. We typically want a higher HRV. So just think inverse on those. The absolute number doesn't really matter that much. You mostly want your HRV to be stable, and then you figure out what your normal baseline is, and then you look at deviations from that. It's a more difficult metric to measure, and depending on the device, the percent error when we look at MAPE, that's mean absolute percent error, it can be off by about 6 to 16%. So that's in either direction, above or below. But most devices are reliable enough to use for trend analysis. And again, we talked about respiratory rate. Again, most devices are generally okay. If it says that my respiration rate is 15 breaths per minute, it might not be exactly 15 breaths per minute, but if I wake up tomorrow and it says 20, even if the number isn't correct, my respiratory rate has probably gone up. And so I think we can rely on those trends, even if we're not looking at those like single values and treating them as gospel truth. So what do we do with these values? Most of these wearable companies, they will put them into readiness or recovery scores. Again, the formula is proprietary, undisclosed, and differs across brands. You can't really audit how the specific value is produced. And lots of times they can just push updates and change how they're calculating them, and don't necessarily disclose exactly what has changed. And so that if your sleep is constant and everything's just fine, and then all of a sudden your values change, It might just be that there was an update. However, I don't want to just say that they're completely unusable. Again, I would treat it more as a red as a flag. Like if for some reason your readiness drops, then you can kind of dive into it. For example, I know that the Aura, they actually, I'll just pop right over to my next slide. So right here, this was one night where I had all five of these five devices on. So I have a Garmin watch, a Whoop strap, an Aura ring. This is the new Fitbit Air, and then an Apple Watch Ultra. So all of these, this is the same night of sleep across all these devices. So Garmin had my sleep score 82, Whoop 87, Aura 86. Fitbit doesn't do a sleep score, so I slept decently well that night. But my readiness, Fitbit said 65, Aura said 86, Whoop does recovery 57, and Garmin battery 66, body battery 66. So again, it's all the same data from the same PPG, like heart rate detection technology, but their algorithms calculate them all differently. For example, Aura, if you do a lot of exercise the day before and your HRV is normal, your resting heart rate's normal. If you were much more active the prior day, Aura will tank your readiness because it doesn't think that you've recovered, even if all of your recovery signals seem to be good. We'll get into now how, for the best that I could tell, what makes up these recovery and sleep scores from these manufacturers. Again, I pulled all of this data as best as I could from the actual manufacturers. So we have Garmin, Whoop, Aura, Fitbit, and Apple. There are more, but the same trends follow. So when we're looking at on the left, we just have our sleep scores. They all take into account sleep duration, sleep staging. Aura and Fitbit definitely do. Garmin and Whoop maybe. They were kind of ambiguous there. Some take into account how regular you are with your sleep timing. And they all take into account your interruptions. So if you were tossing and turning all night or kept getting up for some reason. And then a lot of those will bake that sleep score into your recovery or readiness score. Apple doesn't do their readiness score. Lots of third-party apps use Apple Watch data for that, though. But they all use these core HRV and resting heart rate, all take into account how you slept. And some use respiratory rate, skin temperature, and your activity from the previous day. And so again, it's not to say that the recovery scores or sleep scores are useless. They're all taking into account the signals that we talked about that are valid and reliable. It's just that there isn't transparency in what is in what is presented or how things are calculated. And when we talk about wanting to, actually, no, that's my next section. So we're just going to talk about how to interpret, like, and individualize our interpretations here. Specifically, the main way that we need to understand how these are individualized is to understand what our normal physiology looks like. Typically, what that involves is when you get a wearable, you wear it for this says 30 to 60 days, but you can sort of get an idea what things are going to look like after about a week. Specifically, we're dealing with those vitals like the resting heart rate and heart rate variability. And we can understand what our normal range looks like. If my resting heart rate is normally right about 60, I don't exactly know what one standard deviation from my normal range is, but if I wake up and it's 68 when it's normally 60, then something's going on. Those formulas are helpful when you build it into like an automated management system where data rolls in so you can flag things that are going on. But that's a good general rule. And then with that normal average, we can kind of do a rolling average that's a little more acute. Here's an example of what heart rate variability looks like over time. So you can see we have our daily values that are right here on the blue line, and this like shaded area indicates I think that's one standard deviation normal baseline range, and it's zoomed in a little bit, but you can see that range is shifting as time goes on. And so you can see, like right here, their HRV was above their normal range. Their HRV was below their normal range there. And so that's a good way that you can actually see those flags and understand what those worthwhile changes are. Again, this isn't necessarily a heart rate variability and training lecture. We'll get into just the real basics of that. This is mostly just what we can get from these signals. Comparing people across people is definitely a trap. About 60% of our HRV, and I would say resting heart rate as well, is genetics. Resting heart rate's a little more with training, but our baselines depend on they differ greatly person to person, based off of sex, fitness, ethnicity, age, and so forth. Um, and again, our norms describe groups, not necessarily the person in front of us. So if we take this theoretical individual, their baseline variability, say, is 45. That's their normal. And if they wake up today and their heart rate variability is 42, that's totally normal for them. But if we have another person who their baseline is 72 and they wake up and theirs is 42, something is going on within their autonomic nervous system, whether they had a ton to drink the night before, or whether they are incredibly stressed out, or did a really big workout right before bed. And so understanding what each person's individual baseline is very important. Uh, we'll go in a nutshell how these vitals can be used to guide training decisions. Um, and again, this slide could be its own presentation paper, or there was just a big heart rate variability book published about it. But essentially, if our heart rate variability is at or above our baseline and our resting heart rate is normal, that's indicative that we are responding well to our training, and that we are primed to adapt well to high intensity training. If our HRV is trending down, that could indicate, again, it's not always our training. It could be other factors as well. But that could be indicative of that we are not responding to training, that there's something else going on. Or if our HRV is suppressed, and especially if resting heart rate is elevated, if we had intense training scheduled for that day, it could be a good signal to ease off, and to lower intensity. And there's actually good literature showing that when we adjust training based off HRV, essentially, if we had high intensity scheduled for a day, but our HRV was below our normal baseline, you can reduce intensity and volume on that day, especially if you're doing those intense days, intense training days on where your heart rate variability is in your normal baseline or above, that with lower volume, you can still achieve the same or even more gains. The problem is that in this is more applicable in athletic settings, but tactical stressors and demands don't necessarily match up. You can't just be like, oh, sorry, I can't, I'm not mission ready because my heart rate variability is down. That's not the way that the real world works. And so specifically in tactical settings, I feel like this could be it's more of a flag issue, where something gets flagged and it can start a conversation, trying to figure out what's going on in an operator or special operator's life, to be able to get them to be able to have improved sleep, to have better work-life balance, or whatever. Again, it's much easier said than done, and it's not the be-all end-all, but it can, I think it can help raise red flags for those sort of situations. So when we're aggregating data from many users, the hard part, you don't want to have an Excel sheet and have everybody go and put in their data, because that won't actually end up happening. Traditionally in athletics settings, you would have a full athlete management system where things are ported in. The problem is those can be quite expensive and honestly difficult to work with. There are some specific, like device-specific ecosystems. For example, if everybody has a Garmin watch, there's a Garmin clipboard, which is free. The data can pour in, you can issue training and such through there. We've had recent success building our own solutions, via like AI vibe coded dashboards and things that pull data in automatically when synchronizations happen, with existing analysis that can link up various wearables from different sources. So there are free solutions, and it usually takes a little more configuration and a little know-how, or you get your friend Claude to help you figure it out. But that has been traditionally the tricky part as to how to get it all in one place. But there are ways to do that. The last point that I wanted to drive home is that data don't define people. Why do we monitor sleep? I think that we want to be able to support and not scrutinize. these flags that we're having for resting heart rate, HRV, total sleep time, whatever it might be, should open up a conversation to figure out what are the stressors that are limiting someone's um, capabilities or performance in life, and try to help come up with a plan to help them, to support them in their own lives and their own decisions. Um, I think that we shouldn't override someone's psychological their self-perception of how they're feeling if their wearable says they're not. Uh, we should obviously trust how a person says that they feel as opposed to what the heart rate variability or resting heart rate score might say, or God forbid, a recovery score. Um, trust the person. Again, if you wake up and you feel great and your device says that you slept like crap, believe yourself. If you wake up feeling like crap and your Oura ring says that you slept great, trust the device. Just kind of hack it for however you want to feel better. And I think that again, we're not trying to surveil. We're not trying to catch people in with their hand in the cookie jar uh, or anything like that. We want to be able to help identify how we can help individuals get better sleep, give themselves the opportunities to get those. Um, so in conclusion, not all metrics are created equal. We need to interpret within the individual, individualize that analysis, and understand that monitoring supports the person. It's not to surveil. It's to help people optimize their own recovery, their own sleep. Um, and thank you very much for having me, and I'm happy to answer any questions.
Awesome. Yeah, thanks, Mike. Great. Yeah, great talk. A lot of good information, especially in the wild west of wearables. That a new one pops out every 5 minutes. It seems like.
Yeah.
So if you've got questions, toss them in the chat or unmute and feel free to jump in. I've got a handful of questions that are always fun. So I'll toss one your way while everybody else is thinking and typing. Um, and then so first question, do you think, thinking about like using wearables as a measure of training load, specific, like you can't necessarily gauge if people like are primed for a shift of work, but within the training settings, I think we probably have a little bit more control and power over
Mhm.
what people do and what days. Do you think the level of accuracy of these wearable devices is is to the degree where you could make some of those training decisions based on the data that come through?
That's a good question. We're trying to design some studies to get after that right now. Most of those like heart rate variability and training studies were done with people taking an HRV reading upon waking. Uh, we think that those should line up with the overnight HRV readings that most of these wearables are giving out. But the literature is mixed on that. So we're actually trying to figure some of that out. My hunch says that we published a paper last year, and we showed that the Oura Ring and the Whoop Strap are probably the most accurate in terms of heart rate variability. Everything's just fine for resting heart rate as far as we can see, but especially those ones should be good enough. Like I think accurate enough and reliable enough for HRV readings. And if you're consistently wearing it, I think that you can go off of it. Again, it's not necessarily to only make those decisions based off of that HRV. Uh, it should be a red flag potentially. But I mean, if I feel great, but my device says that my HRV isn't good, but if I feel okay, I'm still gonna go hit the interval session that I wanted to. Again, it kind of goes against what I just barely said earlier, but you can't rely on that signal because there's just like there are so many things that affect sleep, there are so many things that affect uh, our heart rate variability, and so you kind of have to outsmart your wearable sometimes. Uh, but yeah, that was a rambling answer, but hopefully there
No,
was
it
bigger
makes and it
context.
draws me into another question of like at that point you're looking at the data for yourself, but in a lot of these training settings, the individuals who we care about if they are working, if they're overworked or not, don't necessarily have the say of,
True.
hey, I'm going to train today or not. It's like you're here within this academy, you're going to train, unless we then flip it and give data to instructors, or at least maybe not the specific data, but the decision making, like that information, which I think opens up a whole can of worms about how can we make sure it's confidential to a degree that we're not like you don't undermine the trust of the tactical athletes by saying, hey, this is going to be punitive, or there's going to be system level changes once you wear these devices.
Yeah, that's tricky, especially because like and if someone is flagged but others aren't, and someone gets their training adjusted but others don't, so that that like you said, and sometimes the juice isn't worth the squeeze in terms of like dealing with all that, even if you have a perfect flagging system and theoretically you could personalize the training and recommendations towards everyone, uh, in a setting like that, it honestly might not be worth it. Especially if you're no, I'll leave it there.
Yeah, I'd be curious to hear other thoughts. We've got a couple questions in the chat too. So
Okay.
one about air rates. If it's the same device on the same user, how does the air usually, like the direction of the air, go compared to gold standard?
Okay, so like with the resting heart rate, most of those are close enough that like it's not necessarily it's always below or always above. Um, for heart rate variability, it kind of depends if I understand correctly, whenever you smooth heart rate variability signals, they get lower. And I honestly can't remember exactly based off the paper we published, but I would think that they are they might be more chronically lower if they're smoothing it too much. But I honestly can't remember off the top of my head. I don't necessarily think that they were always above or below. I think it was a mix.
Which kind of goes into one of the measures that you reported of mean absolute percent air, which
Yeah.
accounts for that. So in some of the air rates you discussed.
Yeah, we don't care if it's 5% off, above or below. We just care whether it's off or not.
Yeah. Okay, the second question is asking about, as wearable devices and technologies advance, do you foresee or have you seen insurance companies, medical providers use them to advance personal health? That's something that corporate companies might adapt for employees.
I mean, the privacy part in me doesn't want my insurance company to see anything that I'm wearing on my wrist or anything like that. But I think that there's potential there. I think that I know I can't remember if it's Or or Whoop, but someone is trying to integrate. I think they're all trying to integrate more with the like electronic medical records, so you can import that into my chart. So you can take this report into your doctor to show your activity, to show your resting heart rate or anything like that. But I honestly feel like most in the current state, most medical providers aren't really well versed. Not for like medical school has a billion things to cover, and they can't really cover nutrition or heart rate variability that much. But I don't think they'll I think they'll understand like the sleep time. I think that's appropriate and the activity, but so I think those could be useful. Estimates to be like, hey, look here's objective data to show how active I am, or here's how you can actually like quantify how much I'm sleeping, so I can prove that like I promise I'm trying to sleep. So for some of the others, like they might not understand the resting heart rate or HRV metrics, but I do like that idea of being able to present wearable data to show, hey, I'm actually exercising.
Mm-hmm. Yeah, follow-up comment here on this one from iPhone. So I don't know who you actually are, iPhone, but good follow-up. I'm kind of thinking of it like you plug in your phone into your car, so now your hands free,
Yeah.
and that reduces risk. And so
I know that some companies will do like they'll give you a discount on insurance or extra like FSA money if you do like hit activity goals. So I really like that. I think that's sort of separated from the insurance specifically. Um, you're right. I have seen some things like that where you can hook your wearable up and potentially get discounts or extra FSA money like that. So I like those ideas. Yeah.
we've got conclusion. iPhone is Mike Smith. Good to see you. Thanks for jumping in. another question about the implementation and really probably the data stream of information coming in through wearables, and then how could it integrate within like information management systems or EMRs or those sorts of systems? Are there any specific approaches that currently exist and are available, or what are your recommendations? And this might be, I might tap Josh Hagan on this one too if he's in here. Pick his brain.
He was here a minute ago.
I am.
Yeah, Mike, you take it first.
I need to. Yeah, Mike, take it first.
No, I think most of these wearable companies, I mean, they're trying to edge towards that. Like they're all offering like blood draws now and all these biomarker panels. So I think that they are trying to get into that medical space. There are sometimes issues with FDA approvals for some of their metrics, like Whoop tried to come out with a blood pressure thing where they gave you specific values, but the FDA said you can't measure that accurately, and then so they backed off a little bit, and some stuff like that. But I think that the push towards getting that stuff there can be helpful and hopefully can be an asset for patients and their doctors. What are you going to say, Josh?
Yeah, actually, Whoop, FDA just dropped their thing against Whoop like 2 days ago.
Oh, nice.
Yeah, I don't know if it's good or bad, but yeah, no, I think a big thing, like Mike is saying, I think it's just getting physicians to understand the potential value of that data, because it gives you a ton of, like, you might see a patient once a year, maybe, but you don't have any context over, like, you just ask them if they're exercising, how they're sleeping, and they'll give you an answer. But if you actually give them the data, but the big thing is like teaching physicians how to interpret that data, and it's not clinical data and it's not a 12 lead EKG, but it's still valuable. So I think it's part of the fight there. I am encouraged, like what Mike said, that like some of these are offering ways to get blood work done, like kind of they're not doing that. And even Aura will integrate your glucose data from a CGM. There's just another way to visualize the data. And actually, they do a very, very nice job visualizing the data. You take a picture of your food, and it does some interesting like nutrition guidance for you. So I think they're all kind of pushing that direction.
Yeah, that's helpful. Reading this comment again over, I think it's also thinking in the context of like operational settings. Could you tie HRV or even probably total sleep time, something as simple as that, into shift schedules to see who is ready to go on shift versus who needs to take maybe a step back. And I don't know off the top of my head if there's anything that exists that integrates those yet, but I think that's an important direction.
Yeah, the Navy's got some cool work. It's called the Crew program, where they, like, ships don't have like Wi-Fi, so they actually have like a server that directly pulls in all their Aura, because they're working 3 shifts. Like if you're deployed on a ship, like it is 3 shifts and sleep is terrible, and you're supposed to be given enough time, but accidents happen quite a bit because of sleep deprivation. So they did it out of a safety precaution to ideally change schedules. But I think what they're finding is like people are very reluctant to change the schedules. So now they're seeing the information, but are they going to do anything about it? TBD.
Yeah, that's a good point. That's always the tricky situation. Any other questions from the group? Otherwise, I'll pose one to the group and see if we have anybody who is willing to unmute and give it a stab. All right, one question in the chat here. Ooh, it's a good one. Good question.
So yes. Is there a device that I recommend above the others? I mean, I'm wearing 6. I said that like we showed in our paper that Aura and Whoop were the best for like overnight heart rate variability. But if I only had one and I was purchasing just one for myself, it would definitely be a Garmin watch. Because just what Josh said, whatever you will wear consistently to help you create good habits. I run a lot outside and I need that GPS signal. So even if I'm sacrificing a little signal quality, I want an all-in-one watch that can do everything I want to do. And so it's honestly, it's kind of like what exercise will you do? It's whichever one you'll do for the rest of your life. So if you are bent on a wearable and you really want one, if you really hate like something obtrusive like a watch, then get a ring. The ring isn't good for exercise heart rate, but it's really good for sleep. And so you kind of have to do a cost benefit analysis of what you want to get out of it and what are like your no compromise things that you don't want it to have.
Yeah, and I'd echo on that too, thinking in the tactical settings, like some things maybe will interfere more or less with your job duties too. So, like I've heard about rings feeling odd when you're handling the firearm, or nobody likes to sleep in a watch. I guess some people, depends on the size of the watch. So there's some give and take there. So just like what Mike and Josh were saying, whatever you'll wear consistently and kind of fits that goal. Okay, I decided I'm going to save my question for after Graham goes. So let's take another 5 minute stand up, stretch your legs, go look at your wearables, and then we'll come back at 3:30 and we'll kick it off with Dr. McGinnis.
Cool. Thanks, everyone.
Time for our last talk of the day. So I know it's late on a Tuesday afternoon. So let's focus in and hear learn what we can here. So our final speaker is Dr. Graham McGinnis. He completed his doctoral training at Auburn University in exercise physiology, and then had additional postdoctoral training at University of Alabama in Birmingham at the Center for Exercise Medicine and Cardiovascular Circadian Rhythms. Dr. McGinnis runs the EPIC Lab in the Kinesiology and Nutrition Sciences Department at UNLV. His research uses human and animal models to determine how 24-hour cycles in physiologic processes, or circadian rhythms, impact physiologic response to exercise. The lab is particularly interested in how exercise can be timed to maximize training adaptations in heart and skeletal muscle. Dr. McGinnis currently focuses his research on cardiometabolic consequences from a novel form of circadian disruption called social jet lag, which is a fun topic to talk about because I think we all title that here and there. So his lab works with athletes in physical demanding populations to evaluate effective sleep and circadian disruption. And so today he'll be talking about evaluating the impact of sleep and social jet lag on wildland firefighter stressors. Dr. McGinnis, the floor is yours.
Thank you. And like the rest, I'm going to try to share my screen and hopefully not screw this up. And does that look right?
Oh, yeah.
With the exception of maybe seeing all of yourselves. Okay, well, thank you so much for the opportunity to be here. This is really an exciting opportunity, and as Dr. Dial suggested, it's really cool to see a full circle moment where my doctoral student at Ohio State now is off doing really cool work. So we're going to talk a little bit about how wildland firefighters have disrupted sleep, maybe some social jet lag, and how this may impact some of their physiological adaptations and responses to the work that they have to do. So I've got two universities pictured up here. On the left, we've got UNLV, where I am sitting now, but none of this work would have been possible without a really unique collaboration with the University of Montana. And I'll show you why in a couple of pictures. So much credit to University of Montana Grizz and some of the faculty and students there. So a lot of you have probably seen some figure that looks kind of like this dial that shows us a little bit about when our body is best at doing certain tasks. And we've adapted to this nice 24-hour cycle driven by cycles of light and dark and the sun. One of the most popular and highly cited circadian rhythms is actually a pathological one. So at about 6 a.m., we have this sharp rise in blood pressure, which is supposed to help us get up and get ready, rise from a laying down position, and also is the peak in some clotting activity in the body. Now really turns out to be when we have the most and the worst heart attacks out of any other time of the day. So some of the first responders out there may be particularly aware of these early morning calls related to cardiovascular disease. But our body's also good at doing exercise at particular times, and that's actually in the afternoon. So we have our best coordination, fastest reaction time, some of our best cardiovascular efficiency all in the afternoon. And that's when most of our world records are actually set for some of these athletic endeavors. So while this is kind of the zoomed out view of the whole person and what we may be able to do at different times of day, it's driven by this molecular mechanism at the cellular level. So we don't have to get too far into the nitty gritty of this cellular perspective here. But what I want to highlight is that in every cell of the body, in the brain, in the muscles, and the lungs, and some of the metabolic tissues throughout the body, there's a cellular timekeeping mechanism called the circadian clock. And it's basically akin to all of these cells wearing their own little wristwatches, and they know exactly what time of day it is. It's synchronized by when we see bright light at the sun, but also synchronized by when we see bright light from any other device that we use all of the time, including right before bed when we go to sleep. But this response is supposed to be, and is evolutionarily supposed to be, synchronizing us with our environmental light-dark cycle. What I'm interested in is when we don't really behave well by these rhythms, or when we have to time our activity into different times of day. So this red arrow here is to say that in a normal and perfect 24-hour world, we would be able to do everything when our body's best at it. But that's not true. That's not the reality that anyone really lives in. We have to do things when they're scheduled, whether that's family or professionally scheduled. And then also, our 24-hour day doesn't change, or it doesn't stay the same. It changes constantly. We stay up late, we get up early, we change time zones, we change shifts. And this perfect circadian mechanism that drives our physiology is just disrupted. So my lab's been interested in really quantifying how bad this disruption is and what kinds of disruption may be most impactful to physiological performance. So we're going to go through a couple of studies. Two of them are going to be related specifically to wildland firefighting. So this is a really unique population. They are tactical athletes, and they are exposed to a lot of stress and a variety of stressors. So one of those stresses is just hard physical work. They have to hike into remote, austere environments, carrying their tools when it's not accessible by road. So that means they may be carrying a large amount of equipment and load over really adverse terrain. They have been estimated to burn in excess of 6,000 kcals a day when they're on task fighting a wildfire. So that's a pretty intense workload. They're also subjected to sleep and circadian rhythm disruption. So a couple of studies have shown that when they're basically not on active deployment but ready, they're getting pretty bad sleep, so less than 7 hours. But if they're actually deployed, they get much less sleep, maybe less than 5 hours, and it might actually be in the field in a relatively inopportune or austere environment like you're seeing in these pictures. So getting sleep when they can get it, not necessarily in a comfortable manner. The last stressor is really unique to this population, and that's the exposure to PM 2.5, or what we're hearing a lot about in the news and the media lately, is this particular matter that's really small. It's 2.5 microns. And this is something that we can breathe in when we're exposed to burning biomass. It can cross into our bloodstream. It can be deposited into some of the cells in our body, and it can induce a lot of inflammation and other adverse reactions. So while they're out working and breathing hard, they're exposed to this PM 2.5 in smoke inhalation. And this is associated with long-term development of cardiovascular and pulmonary diseases and even cancer. So while this population is exposed to a variety of stressors, not a lot of them have been studied in conjunction with each other. They've kind of been studied in one-off or small combinations. So the first study we'll talk about was really trying to pile all three of these stressors together into one study in a tight laboratory design. So particularly, we wanted to look at sleep deprivation in this chapter. So what we did, this was at the University of Montana. We recruited a small cohort. This ended up being 10 males, young adult, relatively fit, decent fitness, VO2 maxes in the high 40s. We had them come in a randomized repeated measure crossover design where they had one night of either normal sleep. This was at home. This wasn't in a sleep lab in the facility. This was at home sleep, but monitored via phone calls and actigraphy. So they had a sleep opportunity from 8 to 6 on the normal night, and a restricted or deprived sleep condition where they had a 4-hour sleep opportunity from 12 to 4 a.m. The morning after, they came to the lab, they did a couple of pre-exercise assessments, and then we had them do what we called a simulated wildland firefighting bout. So you'll see that abbreviated SWLFF. So they came into the lab, they did an exercise session at 70% of their VO2 max, which was measured prior to starting the study. And what's unique about this facility is that they were able to complete that exercise session while they were breathing in smoke from burning wood. This is not something that my lab at UNLV is capable of doing, nor is it something that our IRB would consent to. But University of Montana has an inhalation core facility that has had a vibrant working relationship at their university for a number of years. And this is a picture from their website to more closely illustrate what this intervention looked like. So they have a wood burning stove, which they burn wood, burning biomass. They traffic that through a couple of dilution chambers and filter it so that specifically a controlled and known dose of PM 2.5 is introduced into an exposure system. And they do this with humans as well as rodent models. This is a human study. So that burning biomass, that smoke actually went into a mask, was breathed by the participants, and then was exhaled the other side of the one-way valve and pumped out into an exhaust system. So a relatively arduous task, which partially explains why we got a pretty low sample size. Our hypothesis was that this one bout of sleep deprivation will make the inflammatory and oxidative stress response to wildland firefighting or simulated wildland firefighting a little bit worse. And that may mimic one of the stressors that they face in the field. Throughout their exercise bout, we monitored heart rate and rating of perceived exertion, where the participants were just asked how hard they were working on a 6 to 20 scale. And if you look at their heart rate, the circles are under the normal sleep condition, the triangles under the single night of sleep deprivation. Their heart rate was identical between the two sessions, and it crept up throughout the exercise bout. So no difference caused by sleep deprivation. And both of these bouts were performed with the smoke inhalation. However, if you look at the rating of perceived exertion, the exercise bout completed after sleep deprivation appeared to be or felt harder to the participants. So an identical work rate shown here by heart rate felt worse. However, we ran a slew of ELISA-based assays to look at inflammatory and oxidative stress markers, and we saw actually a very, very mild response. So even though they did a pretty decent exercise bout and breathed in a decent amount of smoke, we didn't see that the sleep deprivation actually had a negative effect on their inflammatory response. So the conclusion we gathered from that was that physiologically, these young, healthy, active, relatively fit college students who participated in the study were able to kind of respond to this stress adequately and didn't have a really robust inflammatory oxidative stress response. And one night of sleep deprivation wasn't that bad. And it wasn't total deprivation, it was only 4 hours. So we thought maybe what we needed to do was either increase the stimulus or move out into the real world kind of in air quotes here, to think about what kind of obstacles they're encountering under normal circumstances. And also, one of those real world implications is where we'll kind of shift from our sleep deprivation into a different form of circadian rhythm disruption. So Many of you may or may not be familiar with this idea of social jet lag, but assuredly you are familiar with actual jet lag. When you change time zones, you generally feel lethargic, you eat at the wrong time, you sleep at the wrong time, and nothing really feels right. And if you were, on the East Coast and you came out to see me in Las Vegas, aside from all the other terrible things you do to your circadian rhythm, the disruption from just changing time zones 3 hours would be pretty disruptive itself. But it turns out people do this on their own without traveling at all, just by staying up late on the weekend. So we've got this diagram over here to kind of illustrate this point where the blue bars here are the sleep window on a Monday, Tuesday, Wednesday, and Thursday. Maybe they're going to sleep around 10 p.m. and they're getting up around 6. And this blue line here would indicate the mid-sleep point on a work week. But then they cut loose on a Friday and Saturday night. They stay up late. They sleep in late. They shift all of their activities. They shift their meals later. They shift their light later. All of the things that tell our body what time it is. And you can see that in red here with a new line calculating the middle of their sleep point on free days. And then on Sunday, they got to snap back into action and get right back to the work week. So this is a reality for a lot of people, and you can calculate how much social jet lag a person gets by taking the absolute difference between these two midpoints in work week and free days. It's quite pervasive. An early study in 2019 showed that only about 14% of a couple 100,000 people studied in Europe didn't have any social jet lag. A lot of people shifted their behavior by an hour, where about 50% of people shifted by more than an hour. A few people in that 2 to 3 hour range, that's the same as if you lived every weekday on the East Coast and every weekend in Pacific time with me. So it's incredibly common, it's pervasive, it's insidious in the fact that you do this every single weekend oftentimes. This is a behavioral phenotype. So it's not just going out on a trip one weekend and then having the rest of the spring to recover. You are doing this every single weekend. It's very common in young individuals, and it's really common in evening type individuals or evening chronotypes, people who prefer to stay up late, because our work week is typically structured around early morning activities. In the lab, we kind of like to call it shift work light, because it's not actual shift work. It's just when your personal schedule doesn't align with your work schedule. And that can happen even on a normal day shift job. So we started this project with an ROTC cohort at UNLV, and we'll circle back to the wildland firefighters and just have a brief departure here as to why I think social jet lag is interesting in particular. This is a group of people that have to get up and do early morning PT every morning at 6 a.m. and they're college kids, so they have a life, presumably, as well as academic and maybe professional obligations. So we recruited this population at the beginning of a semester. We assessed their chronotype or their morningness, eveningness questionnaire preferences using the MEQ. We assessed their social jet lag using a tool called the Munich Chronotype Questionnaire that asks about their work days and their free days and allows you to calculate the magnitude of their shifting behavior. And we gave them a sleep diary. And then we had them do ROTC training for a full semester with an embedded athletic trainer to monitor for musculoskeletal injury. We also assessed a biomarker of salivary IL-6 to look at stress markers. And at the end of the whole semester, we looked to see who got injured, as well as we looked to see at their Army Physical Fitness test, and this is the old nomenclature for the APFT, to see it's like their final exam for how fit they are and if they're prepared for military enlistment. We looked at each of these independently, so we used their sleep diary for a week to look at their average sleep duration. And we saw that if you took everyone who sustained an injury throughout the semester and everyone who remained healthy, they actually slept an equal amount of time. There wasn't a statistically significant difference. We also looked at their APFT scores, and people that slept more than 7.5 hours or less than 7.5 hours had identical or equal APFT scores. We looked at their morningness, eveningness preferences. So if you're a night owl, you like to stay up later. And we used that score. And we looked to see among the people that were injured versus the people that stayed healthy, there was no difference in their MEQ score. However, we did see a really big decrease in their APFT score, specifically in the evening type cadets. So this goes to our exercise timing point. When you train and when you have to compete can matter, particularly as it is in conjunction with your chronotype or your preferences. So these were night owl, evening type people, but they had to complete their APFT at 6 a.m. So physiologically, they weren't really ready for that, and it showed their APFT scores were very low. And for reference, a score of 180 is actually passing. So these evening type cadets probably had to retest at a later date. So the last shot we took was looking at the MCTQ and calculating their social jet lag. And here's where I find this is interesting. In this group, if you took all of the injured cadets, on average, they had more social jet lag than the ones that stayed healthy. And if you took the people that had 2 hours of social jet lag, they actually ended up doing worse on their APFT as well. So this seemed to be pervasive across these two outcomes, injury and fitness scores. And then we also looked at that salivary IL-6. So you see on the first day of training and on the fourth day of training, they only did 4 days a week, Monday, Tuesday, Wednesday, Thursday. You can see that the people that had the most social jet lag compared to the people that had no or very little social jet lag, they had big increases in this salivary stress marker. So physiologically, it appeared that people with social jet lag in this cohort were more likely to get injured. They had poor performance, and they appeared to have a more stressful response to exercise. Flashing back to our population of interest here with our wildland firefighters, we wanted to see if these two characteristics, our chronotype and our social jet lag, impact how they respond to training. And we found an opportunity, again, in collaboration with the University of Montana, where they were doing a study evaluating people's response during a critical training period, or what some they call a critical 80. It's a 2-week training period right before the start of the firefighting season, where they do in-depth training, physical fitness tests, 2-a-day work, and it's a really brutal 80 weeks of training. So we were working with Montana, and we incorporated the same questionnaires, the MEQ to evaluate their chronotype or their morningness or eveningness, the MCTQ to evaluate their social jet lag, and then a slew of other outcomes, anthropometrics, body composition, and some blood panels to look at their response. So we let them loose on their critical 80 training period. They had an activity monitor. They completed training logs as well as sleep logs and soreness visual analog scales. So they basically had a line to show how sore they were or how poorly or how well they slept. At the conclusion, they completed the same baseline measurements with anthros, body composition, and blood draws. So we ended up working with 2 hotshot crews, and this is a relatively high-performing group amongst wildland firefighters. One was based in California and one was in Arizona. We had 25 people in total, with 22 males and 2 females. And our hypothesis was that people with later chronotypes, which have pretty systemically been shown to do worse with training programs, that they would have a worse response during the critical training period. And participants with high levels of social jet lag would also have a worse response to critical training, similar to what we saw with our ROTC cadets. So if we take a look at our chronotype data first, we see that surprisingly, we actually didn't get a full distribution of chronotypes. We only had a group of morning type individuals and intermediate chronotypes. We didn't have a single evening type wildland firefighter. So that was a bit of a disappointment, but you can't control who you get in a study sample. So we let them, we analyzed what we got. And if we look at upper body soreness and lower body soreness, this was the first week of the critical training period. They actually had weekends off, which gave us the opportunity to look at social jet lag. And then the second week, they did really great on all of their assessments, except for the last day. Nobody completed almost any of the outcomes we wanted, so we just excluded that data because we lost sample size on Friday, the last Friday of training. But it looked like our intermediate types tended to be a little more sore, both in upper and lower body, but nothing statistically really panned out there. We also looked at, among our slew of biomarkers, we looked at lactate dehydrogenase and creatine kinase. These are two muscle damage markers, things that get released into the blood when our muscles get damaged and our cells break down. And again, we did not see anything statistically different between our intermediate and our morning types, but it appeared, the first bar is their baseline, the second bar is their post-training period blood draw. It appeared that the critical training period elicited a big increase in our muscle damage markers. It appeared to be a little bit worse in our intermediate chronotypes, but nothing statistically significant panned out there. Our last try was to look at our MEQ score as a continuous variable, and we ran a correlation between the change in lactate dehydrogenase and creatine kinase from baseline to follow-up against their MEQ score, where the higher number actually indicates eveningness, and the lower number indicates morningness. And we actually saw, I'm sorry, I think I have that backwards. We saw that there was a non-significant association between these, MEQ score, the raw score, and the change in lactate dehydrogenase. So this effort was slightly hampered by our ability to recruit various chronotypes. We only had morning types and intermediate types, but it looks like maybe the intermediate types were a little more sore. If we follow that with our analysis based on social jet lag, we broke our population up into people that had less than 2 hours, or sorry, this is a typo. This should be less than 1 hour of social jet lag or more than 1 hour of social jet lag, where the people with social jet lag are the red line, and you'll see red bars over here. As far as upper body and lower body soreness, we actually saw that our people with social jet lag may have had some better weekend recovery, where their levels of soreness dipped over the weekend compared to our people without social jet lag that stayed a little more consistent throughout that time. But what I thought was interesting was in the response coming back to work that second week, we saw a sharp increase in our upper body soreness that was significant by Tuesday, and a trend towards an increase in our lower body soreness by Wednesday in our people with social jet lag, which suggests that maybe they came into that work week of training and that soreness that shows up a day or two later was kind of elicited by some circadian rhythm disruption on a Monday. If we look at our muscle damage markers, again, lactate dehydrogenase and creatine kinase, again, statistically, we only saw that exercise elicited an increase, which is not a surprise. But if we look at the correlation between the change in lactate dehydrogenase and the magnitude of social jet lag, we did actually see a significant association there, and a near significant trend in CK, indicating that among our wildland firefighters, those with social jet lag tended to have higher muscle damage markers, and they might have increased soreness after that weekend, although it did appear that they recovered well during the weekend. So to conclude, we had a couple of studies to talk about here. Our acute sleep deprivation study suggested that just one night of sleep deprivation makes things feel harder, but didn't make things physiologically harder. The heart rate stayed the same. The inflammatory markers stayed the same. So a longer, more drawn out sleep deprivation protocol might have been required to really show how deleterious sleep deprivation can be. Our second study with ROTC cadets showed that social jet lag was a big negative indicator for musculoskeletal injury, APFT performance, as well as inflammation. And that was unique in that analyzing sleep duration and chronotype alone didn't have quite quite as pervasive effects. Lastly, during our critical 80 2-week training period, social jet lag was associated with increased markers of muscle damage, indicating that those people that have social jet lag as a behavioral phenotype may be more prone to some muscle damage during heavy physical work. So the previous speakers did an excellent job of talking about how important sleep is and measuring sleep can be. So I'll echo their sentiment to also highlight that sleep is super multidimensional. Duration is not sufficient to really encompass how good people's sleep is. So what I like to highlight is that consistency really matters. And even if you can get 8 hours of sleep, if you get 8 hours of sleep at a different time of day and you shift it consistently, that variability has important ramifications. It's not always possible, and it's certainly not possible for people that are responding to emergency situations. But when it is possible, even if it's during a physical fitness test, integrating exercise timing can be important, particularly if you have people who have strong chronotypes. We saw those evening type cadets do very poorly on their physical fitness tests at 6 a.m. And lastly, the take-home message that social jet lag is super pervasive. It's less common for people not to have social jet lag for young adults, particularly, and it's insidious that we do this every weekend more often than not. And this is not unique to shift work. So even if you're working with a population that isn't a night shift work population, maintaining consistency in your sleep schedule can be really important. So I will thank the funding sources, the lab members that contribute to this, especially Dr. Dial now at Ohio State, and Dr. Malik at 8 Sleep, and the group at Montana that made that inhalation work possible. And I'll open up for questions.
Awesome. Yeah, great stuff. Appreciate that presentation. Got my mind running in a lot of ways. Just the inhalation study in general is crazy to run that in a lab. I love it. Yeah, if anybody's got questions, I think just like what you were presenting, probably a lot of us have social jet lag at one point or another. We've gone through those ebbs and flows, so it probably hits close to home for some folks. So while people are frantically typing their questions, I'll go ahead and ask one. So do you think folks with the evening type, like chronotype, are more prone to social jet lag, and that's where some of that relationship between like just the chronotype and the performance happen, or did you control for that within the studies? I think I just missed it.
So yeah, at a population level, people that have an evening chronotype tend to have more social jet lag just because the general structure of school timing, work timing, our work week obligation timings are all kind of built around an intermediate to morning chronotype. And even with kind of, I would say, societal norms and societal pressure, the early bird gets the worm. That's true, but if you're not an early bird, that's kind of sucks for you. So given that our expectations are set up around this early work time, it's typically people that have later evening preferences that have more social jet lag.
Yeah, that makes sense. And it makes me think about like the ramifications within shift working populations of how can we time up the shifts appropriately based on people's natural chronotype, which in a lot of cases it's like a bidding system and it's seniority based. I'm curious if anybody on the call has had those discussions or thought about that within their agencies regarding like, are people night owls versus what's the opposite of a night owl?
Morning lark.
Okay. I wouldn't have got that one.
Yeah.
but then timing up like shift work or shift schedules around that. Just toss that out there if anybody wants to chime in.
It would be interesting to find kind of a more chronotypically synchronous type of workforce, right? You know, if you have people that are really great at staying up late, they could be allocated to a shift that requires that type of schedule. But one thing that I've kind of heard from a lot of the groups that we work with is beyond personal preference becomes includes family preference, and if that's shift length, and we know that shifting more frequently for short shifts can be more harmful, then the logical conclusion would be to extend the shift. But the family obligations would say if you extend that shift, that's harder on the family. And it, you know, kind of brings into the whole person mentality there.
Yeah, that's a great point. Exactly in line with the comment that just came through about working swing shifts. And so social jet lag happens every week on an extreme scale, going from a 5P to 3A and then back onto a 6A to 4P, just opposite. So then the question, which is a great, I love it. Can social jet lag be trained, or can people adapt to it if it's consistent? Like if the swinging schedules are consistent, can you adapt to it? Because in Mike's point, he makes a sacrifice so he can be home with family, just have family time.
Yeah, I think, and I guess we're kind of at the end of the session, so anyone can chime in, the previous speakers as well. From the chronobiology world and some of the conferences I've been going to, a lot of mention of things like meal timing with shift workers to we basically have three ways to tell our body what time it is: the light we see, the food we eat, and the physical activity we get. So if you can control those timing cues to be consistent in your, you know, normal diurnal day, even when you're on shift, and you limit the amount of food you eat on shift to the extent that you still have the nutritional, you know, you have the nutrition on board to do your job appropriately. But it can help limit kind of shifting your body clocks to be out of alignment during the night shift. So some studies have been done on like night shift nurses and things like that, where they try to limit their food intake late at night and only have kind of inter-shift snacks to maintain energy and things like that. But ultimately, you know, we're supposed to be awake and active during the day, and our 24-hour world does not allow that to be true for everybody. So it's a hard thing to do, and I don't think there's a single answer to making shift work tolerable or healthy.
Yeah, it's just complex. Like it's complex. There's so many layers to it, like nutrition timing and light exposure and all of these things that play into like when you fall asleep realistically. Um, but then it's a habitual thing, like you were mentioning. So how long does it take for the negative consequences of social jet lag to show up?
So with single time zone shifts, like you would get with traditional jet lag, typically the standard is that your body shifts about one time zone per day that you've traveled. So if you flew from the East Coast out to Pacific time, then it would take you about 3 days for your body clocks to be fully synchronized. So for our ROTC cadets that were doing kind of a 4-day work week, and some of them had social jet lag in excess of 3 hours or up to 4 hours, by the time they were actually getting back aligned, they then shifted back on the weekend and went to a different schedule. So it's ended up being this kind of meandering of your body clocks, where it takes a few days to become aligned, and then you go back to a free living condition or back to your home time zone. But this is kind of, as I was saying, it's really common in younger individuals. And this was recently highlighted in the Clark County School District. They've restructured the school start times because our high schoolers have the latest chronotypes and they have the earliest school start times. So they've shifted that to try to help realign the academic schedule with the kind of the biological schedule of these individuals. But presumably, you asked about the timeline of how long it takes for social jet lag to be to have a negative effect. It's something that exists through adolescence as soon as they have a school start time, essentially, and is pervasive maybe through adulthood. So this has been associated with poor metabolic health and physical activity and diet in children. So it's a hard question to ask, but at the population level, it's pervasive and has negative effects in children. Some tightly controlled lab studies have shown a single weekend can throw off things like blood pressure and some cardiovascular autonomic measures. So it could be one weekend or it could be your entire childhood. I don't know.
Yeah, that's fascinating. Yeah, that's really interesting.
If you've ever flown with toddlers across 3 time zones, it takes at least 14 days to re-regulate.
Yeah, agree.
Yeah, speaking from some recent experience there, Mike.
Also, Graham, how long have you wanted to say the words chronotypically synchronous schedules?
It's been on the back burner for a little bit.
Yeah. Okay, I got one more question, and then if anybody else has any, chime in. So you mentioned right at the beginning, when you're briefing on circadian rhythms and clocks, and you mentioned that blood pressure is at its highest earlier in the day, and that's where most of the heart attacks tend to show up. And we know for fire and for law enforcement that cardiovascular events are a big problem. And so I'm curious if you've seen anything, because I haven't specifically looked, relating cardiac events for first responders with really like start and end time of what tends to be that third shift, first shift trade-off kind of point.
I haven't seen the data specifically on that, but the hallmark of that early morning increase in blood pressure coinciding with increase in cardiovascular events kind of rests on the fact that we have some kind of normal rhythm. So you would almost expect that people that are shift workers that have abnormal circadian rhythms, they're at an increased risk for cardiovascular events to start with, but they might not be as equally time distributed because their circadian rhythms so disrupted to start with. But I don't know. I don't have the data to back that up. I don't know if anybody else has seen that. If like the morning window of cardiac events still persists in shift work.
Yeah, I'm not sure, but that does make sense that like they shift their rhythms are a little bit different, so it might not time up the same way.
This is kind of an off-topic response, but there was this old 1990 study that looked at people in Hawaii that were having heart attacks specifically, and Native Hawaiians or people that lived in Hawaii were having their biggest and most frequent heart attacks in the morning, but the tourists that had heart attacks in Hawaii had a heart attack corresponding to the morning of where they're from, not the morning local time. So their circadian rhythm was still kind of persisting in that morning surge in blood pressure from their home time zone. So it was a really unique way of looking at that persistence of the circadian rhythm as it's related to cardiovascular events.
Yeah, that's super interesting. I mean, all this stuff just makes me recognize how layered it is when we're trying to change behavior using all the tech we can find, and hopefully it's accurate, which we're getting there. And then you run into the beast of shift work and trying to figure out how to align schedules when people also want to have a life outside of work, and that kind of throws a wrench in the whole problem. Is there anything we can do to make our circadian rhythms more adaptable? Make that the final question. This can be for everybody too.
I think yes. I think that a lot of the things from the athletic population is things like pre-entrainment So if you know that you need to compete at a specific time, start training your body to in your practice or in your training to be active at that time. If you're going to know you're going to compete in different time zone, you can shift your practice schedule to meet that time zone, or you can travel early, things like that. I don't know how well that fits with this idea of constantly rotating shifts because you're constantly rotating. But um, in a single bout, yes, you could be more flexible. I don't know what the other speakers have to add to that.
Shannon, I don't think we've got your audio. No, nothing.
Any better?
Yep.
I think from a organizational shift work perspective, I think it's how we structure this or how organizations structure this. So for 12-hour shifts, is it a forward rotation? Are we having people switch back and forth quickly between a day shift and a night shift? What is what's their commute time? I think there's some evidence to suggest that have people work permanent days or permanent nights. I think that largely underrepresents the social ramifications of that, particularly for recruitment and retention purposes. Having young adults or young people with families or without, having them work permanent nights is not conducive to retaining those folks in your organization. On 24 and 48-hour shifts, it's a public service that we have to fill, but can we do it more successfully? Can we have start times change? Can we meet people where they're at when it comes to training windows on that sort of thing? So I think from an organizational perspective, there's a lot we can do that that still has yet to be done. And I saw somebody mention in the comments about Battalion Chief Binney out in West Metro, Colorado, and that's one of the studies referenced earlier, but they're looking at a start time change, and they made the start time change, and they're evaluating that now within their personnel. So they're just west of Denver, so they have long commute times. They work a 4896, so their folks are on shift for a long time. They have high call volumes. They're a combined EMS fire service, so their folks are running all day and all night. And so what they're able to do is evaluate how people are, what their shift looks like on day one, and then do they need to move them to another part of the county for recovery purposes so that they can reduce provider errors and those kinds of things. So the work is being done. So we're slowly seeing it start to come to fruition.
Makes me think on a similar vein. We have some data we're analyzing now with within a fire and EMS department here locally, and one of the things that we're seeing is what type of calls people go on and the severity of just the events. Was it a very traumatic thing, and how does that influence their sleep the night after as well, and in subsequent nights too. So that'll be interesting. We're analyzing the data now, so just stay tuned for next time. Okay, awesome. The last thing I'll share here. So before I talk about this, thank you to all three of our speakers. Y'all presented great information that I think is helpful for us and the tactical community to consider when we're trying to help folks sleep better. So great job. Appreciate everybody tuning in and jumping on. If you're local, if you want to travel, our next TACH2F will be in December 18th. We'll be on campus, and we're gonna jump in some float tanks. We'll sit in some vibroacoustic therapy chairs. We'll do some sensory enhanced mindfulness activities. We're gonna do the whole gambit. So if you come on campus, we'll talk about the mechanisms of recovery, what we can do and how we might want to roll these out within our first responder organizations. Because I think sleep probably number one primary way to recover, but maybe there's some other ways we can augment it too. So we're gonna explore that and kick some tires. It's gonna be pretty fun. Then my last ask, which we'll also send out in an email, so everybody has my contact information, but also the survey. We love feedback. Share what was good. Share what you think should improve in the future, and we'll continue iterating, make this thing as good as possible. Thanks everybody for tuning in. We'll cut the recording here, and if anybody wants to hang on and chat, I'll stick around, and anybody else is welcome. Thanks everybody.